Hello everyone, welcome to another interesting session in pathology. Here we are going to discuss about the very first chapter, that is actually, even though it is mentioned as the second chapter in Robbins, this is actually where we are going to start our proper general pathology. Okay, general pathology. And remember, we have around 9 to 10 chapters in general pathology, starting from the cell, the unit of health and disease, which I have already finished, to that of the problems faced by or the diseases of childhood. All those comes under, or till we can say about infectious diseases. So around, I think around 8 chapters, around 8 chapters we will have under what we call it as our general pathology. Okay, yes. So hereafter, yes, remember target, next and INICET. So I hope you all are aware of this. Fine, yes. So hereafter, within a year, most probably from 2023, all the exams will be replaced by the national exit test, which will be a unified entrance exam, or we can say the INICET, which is an exam for the central institute. So I will try my best to cover all the high yield points, okay, because these are not mentioned in Robbins, and okay, I have referred some other books to give these high yield points, but remember, these points are the most frequently asked question in the central institute exams, like AIMS, PGI, JIPMA, all those. Fine. So let us start with high yield for the next and INICET: cell injury, cell death, and cell adaptations. See, pathology is nothing else but what we are going to learn in pathology. Two stuffs. Number one is what is etiology, and number two is pathogenesis. What do you mean by etiology? They are the causes. For example, I am getting lung cancer. What are the factors which leads me to develop lung cancer? That is called as etiology. For lung cancer, the most common etiology is smoking. Pathogenesis. See, okay, whoever smokes, whether they are developing lung cancer? No, of course not. So there are some mechanisms which leads to the development of lung cancer. We call it as pathogenesis. Fine? Yes. Remember, normally cell will have homeostasis. What do you mean by homeostasis? Walter Cannon and Claude Bernard Shaw has named those terms of homeostasis. But whenever the cell undergo some stress, this stress may persist for a very short period of time. Sometimes it may persist for a very long period of time. When the stress persists for a very short period of time, we call it as a reversible cell injury. And if it is persist for a long time, it will lead to irreversible cell injury. What do you mean by reversible? Why it is called as reversible? For example, I am taking more cholesterol. That is reason for my fatty liver. Okay, at a particular stage of fatty liver, when I decrease my cholesterol triglyceride intake, the liver will become normal. That is reversible. Suppose I am taking alcohol for a very long period of time, like daily I am drinking 3 times for a month. Within a month, I will develop liver cirrhosis. Fine, yes, or we can go for liver failure, and that is irreversible. The liver can't manage, or it can't bring back its normal functions. So, what are you can see in this picture various genetic abnormalities whenever there is any trauma, okay, and whenever there is some structural changes, biochemical changes, infections, toxins, immunological abnormality, genetic abnormality, all this will cause some etiology, and this etiology will further cause some structural and biochemical changes in the cell or the organ. We call it as the pathogenesis. Finally, it will lead to some molecular, functional, and morphological abnormalities in the cells and tissue, and finally, that is responsible for the clinical manifestation. What is clinical manifestation? The signs and symptoms. Symptoms is what the patient says. Signs is what the ones we elicit. For example, what to say? Yes, the patient will come with yellow discoloration of the bulbar conjunctiva. Okay, that is what we call it. You call it we elicit that as jaundice or icterus. Fine. Yes, that is symptoms and signs. Fine. Then why this cell injury occurs? I told you we have a normal cell, okay, which may have leads to a reversible injury, but when the persisting stress or when the persisting stimulus persists for a very long period of time, it may go to what we call it as irreversible cell injury. And here comes the very first question: what are the irreversible cell injury we should study of? Number one is what we call it as necrosis, and number two is what we call it as apoptosis. Necrosis and the apoptosis. No worries, I will tell in detail what is this terminology, what is the difference, everything in today's session. See, what are the causes of cell injury? Number one, hypoxia or ischemia. Hypoxia means deficiency of oxygen, am I right? Or ischemia means reduced oxygen supply or blood supply. When the blood doesn't reach an organ, myocardial infarction. What do you mean by myocardial infarction? Yes, the blood is not reaching the myocardium properly. As a result, the tissue will go for hypoxia. Finally, it will lead to death, tissue death. That is, we call it as an infarct. Then toxins, infectious agent, immunological reaction, genetic abnormality, nutritional imbalance, physical agents, and aging. So all those, just remember this picture. When they ask you what are the causes of cell injury, draw this picture. That is more than enough. Fine. Even aging, when we become old. When I become 50 or 60 years, how my body is functioning now, whether it will be same at that time also? No, there will be a lot of changes. We will see in detail about the mechanism of aging in the end of this chapter. Fine? Yes. So coming to the reversible cell injury. What do you mean by reversible cell injury? Just remember one point. Reversible cell injury means the damaged function and the morphology can be restored when that injuring stimulus is removed. I have to give you a very beautiful example about liver and cholesterol intake. That is the reason. Yes. How do you know that? Yes, here comes the pathology. Okay. Suppose a cell has undergone cell injury. If you observe, okay, I'm taking a cut section of the liver. I'm taking that cut section of the liver and I'm going to observe under microscopy what are the morphological changes, whether it is okay in the reversible injury or whether it has gone to irreversible injury. How we are going to differentiate? In reversible injury, there will be what we call it as cellular swelling, number one, and number two is what we call it as fatty change. What do you mean by cellular swelling? That means whenever there is an increased permeability of the plasma membrane, okay, there will be some small clear vacuoles in the cytoplasm. There will be distended endoplasmic reticulum. Okay, yes. So all this will appear like what, like a swelling. Okay, there will, you can see cytoplasmic blebs. You can see. Okay, and actually this morphological pattern is called as hydropic change. What is this morphological pattern called as? This is called as hydropic. Okay, hydropic means water. That means the cell will looks as if it is filled with water. Also called as vacuolar degeneration. Why it is called as vacuolar degeneration? Why? Because the cells is completely, the cytoplasm are completely filled with the vacuoles. Don't worry, we will go for a picture. You will understand. See, this is a cut section of the kidney. What you are seeing here, of course, I know it's very difficult to appreciate, find out that whether it is a kidney, but just remember, okay, what you are seeing is various cut section of the tubules. So these are the normal cells. As you can see here, as you can see in this picture, the second picture in B, see the width here, this is the width, okay, this is the width. You can see here the width has increased, here, and you can see some various blebs like this, cytoplasmic blebs, okay. Fine. You can see various blebs like this. So all those indicates what? All those indicates yes, reversible cell injury. So that is actually called as cellular swelling. Okay, yes. And another one example. Okay, and or another one feature. What you want to see is, you can see compared to this picture, you can see increased eosinophilia. Okay, compared to this picture, there is increased eosinophilia. Compared to this, you can see what we say called as increased eosinophilia. Fine. Yes, that is a very, very important point. Fine. Yes. And in the picture C, what you see is, nucleus is completely lost. There is complete fragmentation of the cells. So this is actually irreversible cell injury. Okay, this is actually irreversible cell injury. Okay, there will be complete fragmentation. You can't appear. See, when you look, you can see in picture A, when you see the first site, you can understand, of course, it is kidney. In the second also, okay, the complete architecture is still preserved. Am I right? Yes, you can still appreciate that it is a kidney. But when you go for picture C, can you still appreciate it's a kidney? No, you can't appreciate it's a kidney. You can't identify which organ it is, because complete fragmentation, complete leakage of contents. So I hope it is clear. It is irreversible. There is another very, very important question which comes here. Okay, this is actually especially for your INICET exam. What is ballooning degeneration? Okay, in hepatitis, in viral hepatitis or acute and chronic hepatitis. Okay, we have something what we call as a ballooning degeneration of the liver. That is also a type of hydropic change. It is also a type of cellular swelling. Just remember, ballooning degeneration of the liver occurs in viral hepatitis. It is a reversible. It is a sign of reversible cell injury. That is a very, very important point I have to stress here. Focus for INICET exam. Fine. Okay. Then that is the first change. Coming to the second change, that is nothing else but the fatty change. Okay, fatty change. Actually, fatty change means what? You will have lot of lipid vacuoles within the cytoplasm. Okay, that is mainly encountered. It's not present in all organs, mainly in livers and liver. Okay, yeah. So what are the other features? So there will be plasma membrane alterations, blebbing, mitochondrial change. Okay, that is very, very important. Okay, the first feature is plasma membrane blebbing. Okay, then I have already told you dilation of the dilation of the endoplasmic reticulum. I have already told you the nuclear alterations. Then we have two more changes. One is mitochondrial changes and another one is what is myelin figures. See what you mean by the mitochondrial changes. Okay, let us see what are the mitochondrial changes. Mitochondrial changes means, see, there will be, mitochondria has outer mitochondrial membrane, inner mitochondrial membrane, lot of enzyme system complexes are present within it. All those will leakage. There will be breakage of the uniformity of these membranes. Finally, what will happen? The mitochondria will appear in the form of some amorphous densities. Amorphous densities in electron microscopy. It is not visible under light microscopy. It is under EM, electron microscopy. I have very clearly, I am mentioning, their questions are, see, the examiners are very tricky. They will give you the question, okay, which of the following is the earliest sign of cell injury, which can be appreciated in light microscopy? Which of the following findings cannot be appreciated in light microscopy? Answer is amorphous densities. Amorphous densities of the mitochondria can be only appreciated in electron microscopy. Rest all changes you can appreciate under normal light microscopy. Fine? Yes. I will show you. Then the next one is called as myelin figures. What are myelin figures? See, as you can see in this picture, that is the phospholipid bilayer which is present in the plasma membrane. They will undergo aggregation to form some concentric lamellar myelin figures. Okay, as you can see here, you can see the concentric lamellar. Okay, you can see the various lamellae here. Yes, these are actually nothing else but called as the myelin figures. Remember, as you can see in this picture, it is actually a electron microscopic picture. So again, this finding is also appreciated only in the electron microscopy. Okay, I hope things are very clear for you. I hope things are very clear for you. Yes, okay. Then so that is myelin figures. I hope things are clear for you. Okay. Then so this is a reversible cell injury. Now I am giving this injurious stimulus to the cell for a very long period of time. Now the cell is going to undergo irreversible cell injury. Irreversible cell injury is characterized by three important features. Like I told, cellular swelling for reversible. For irreversible, we have three features. These three features should be there. Okay, should be there, or these for to say that okay, the cell has undergo irreversible cell injury. Number one, inability to restore. As you can see, inability to restore the mitochondrial function, loss of structure and functions of the plasma membrane, and loss of DNA and chromatin structural integrity. Mitochondria should be gone, plasma membrane should be completely gone, and the DNA integrity should be lost. So this is what we call it as irreversibility. I told you we have two irreversible cell injury, necrosis and apoptosis. We are going to see them each in detail. First, let us see what is necrosis. Necrosis is nothing else but an accidental cell death. Necrosis is nothing else but what? It is an accidental cell death. Okay, yes, for example, like ischemia, infections, any trauma, all this. Necros means death. Okay, yes, in all these encountered injuries. So I can say necrosis is usually pathological. Necrosis is usually physiological. It's not physiological usually. Okay, or not physiological, I can say, because normally the normal cell in our body, why you should harm itself to undergo necrosis? No, it won't do. Fine. So suppose I am traveling, I met with a road traffic accident, I got an injury in my lower leg. Okay, at that time the tissue presents there, the muscle present there, it may undergo necrosis. So that is what I told, that necrosis is usually pathological. Fine. Let us see the differences between necrosis and apoptosis. Okay, this table you should know. Now I will be telling only about necrosis. In necrosis, you can see the cells are going to shrink. The cells are going to enlarge or swell. Like our reversible cell injury, in necrosis, the cells will be swelling. What will happen to the nucleus? The nucleus will undergo three phenomena. We call it as pycnosis, karyorrhexis, and karyolysis. I will explain each term, no worries. Then the plasma membrane will disrupted. This is a very, very important point, children. Very, very important point. The plasma membrane will be disrupted. So one cell is undergoing necrosis. The plasma membrane disrupt. The enzymes present within that cell will leak, and this will stimulate the inflammation of the surrounding cells. That is why in necrosis inflammation is present. Whereas I will tell very soon, in apoptosis the plasma membrane remains intact intact, so there won't be any adjacent inflammation. Okay, now you understand. Suppose a diabetic patient comes to the surgery OPD, okay, with a small leg ulcer. After some 1 week, you can see that the whole of his the foot will be involved. What is the phenomenon happening there? Necrosis. Okay, necrosis. Whereas in apoptosis, the one cell, it will die itself. That's all. It's not going to harm any surrounding. It is not going to damage any of the adjacent cell. No inflammation, nothing. The patient is perfectly all right. I hope things are clear for you. Yes. So the enzymatic digestion, see, the cellular contents will leak, so the adjacent inflammation will be present, frequent, and it is usually or invariably it is pathological. Okay, so these are the features of necrosis. Fine? Yes. And fine. See, this is the duration of injury. You can see here how, okay, first you can see for some period of time there will be a reversible cell injury, okay, and followed by that, when the irreversible cell injury occurs, first the cell death will happen, ultrastructural changes will happen, then light microscopic changes, and finally gross morphological changes. See, you can see this is the direction of the duration of the injury. You should know this picture because it has been already asked in AIMS. Okay, this picture has been asked. They have asked to label what is 1, 2, 3 and 4. I hope things are clear for you. Okay. Then we have something what we call it as apoptosis. Apoptosis is a programmed, it is a regulated cell death. That means the body knows, the body itself have a protocol. Okay, if this cell wants to undergo apoptosis, these are the pathway, these are the mechanism it should undergo. The body itself will decide like that. So it is a programmed cell death. We have something called as necroptosis, which is a combination of necrosis as well as apoptosis. We have something called as pyroptosis. We have something called as pheroptosis. Pyroptosis, necroptosis, all these are the recent updates. Okay, they have been explained in detail in Robbins 10th edition only. Okay, so those who are following the older editions or something, please, I will stress, in depth about those topics. So as of now, okay, leave those things. Now we are going to see necrosis. Fine. What is necrosis? It is a form of cell death in which the cellular membrane will fall apart, cellular enzyme will leak out and ultimately digest the cell. You can write, I told you, loss of mitochondrial function, loss of plasma membrane integrity, loss of DNA integrity. These are the 3 cardinal features, hallmark features of irreversible cell injuries. Fine. Yes. Let us see what are the morphological changes. As far as pathology is concerned, you have to write 2 things. One is gross morphology and one is histopathology. Okay, whatever diseases, this is the thing. Okay, there is a proforma you should maintain. For whatever diseases they are asking, there is a proforma you should maintain. Okay, what is the proforma you should maintain? Number 1, whatever question they are asking. For example, they are asking about necrosis. They are asking about necrosis. First, you are going to define. Number 1, you are going to give a definition. Okay. Number 2, you are going to see the mechanism. Okay, how it is undergoing. Number 3, you are going to see the gross morphological features, and number 4, histopathological under microscopy, or you can write instead of histopathology, you can see microscopy findings. Okay, findings. So suppose if it is diseases and all, you have to also include etiology. Okay, what are the causes? Okay, and the mechanism in such cases you will explain in detail. So this is the proforma. Okay, this is how you should present an answer for your professional examinations. Fine. Okay. Then coming to what are the features of necrosis? What are this? Number 1 is cytoplasmic changes. There will be increased eosinophilia. There are 2 reasons for why there is an increased eosinophilia in necrosis or any irreversible cell injury. Number 1, due to protein denaturation. Number 2, there is loss of basophilia. Because of loss of basophilia, eosin is dominating there. Why there is loss of basophilia? That means basophilia means what? That is hematoxin staining. That hematoxin usually stains the nucleus. That is why I told irreversible cell injury, there is loss of DNA integrity. So there will be loss of basophilia. Fine? Yes. So that is another one thing. And okay. Then the cells will also have a glassy homogeneous appearance. Okay, glassy homogeneous appearance. Why? Because of the light, glycogen, all those particles, they will get damaged. And the next one is what we call it as the myelin figures. But remember, here comes a very, very important question. It's a controversial question also. Whereas the myelin figures is present in reversible cell injury or irreversible cell injury. I am giving clear-cut view. Even MCQ books have a lot of errors. Myelin figures are a characteristic features of reversible cell injury. That's why I have discussed here. I am writing again here. Myelin figures means reversible cell injury. Which of the following is not a feature of irreversible cell injury? You can go for the answer of myelin figures. Okay, because the myelin figures, this is actually a feature of reversible cell injury, not the irreversible cell injury. Okay, it is a feature of reversible cell injury. It is well mentioned here. See, myelin figures are more prominent in this in necrotic cells than in cells with reversible cell injury. Okay, see, because why? Because in Robbins, there is a controversial statement here that is myelin figures are more prominent in necrotic cells than in cells with reversible injury. Okay, so what it means? That means they are telling that in necrosis only the myelin figures are more prominent. Actually, it is a controversial because a lot of in good authors and all some other MCQ book authors, they have told that myelin figures you can go. Of course, it is not wrong if you mark myelin figures in necrosis, but more appropriate, of course, you can go for myelin figures in reversible cell injury. Fine, yes. And of course, the plasma membrane is damaged, the enzymes will come out. So what will happen? Of course, you can see large amorphous densities. Here comes the question: amorphous densities in mitochondria are a more characteristic feature of necrosis or reversible cell injury. Necrosis means what? Irreversible cell injury. Here comes the question. It has been an AIMS MCQ. Whenever the examiner asks you about the amorphous densities, please mark amorphous density are a characteristic electron microscopic findings in necrosis or irreversible cell injury. So remember, myelin figures in reversible cell injury, amorphous densities of mitochondria in irreversible cell injury or necrosis. Fine, yes. Then what is pycnosis, karyorrhexis, karyolysis? They are the nuclear changes. Pycnosis means nuclear shrinkage. Karyorrhexis means nuclear fragmentation. Karyolysis means complete loss of basophilia. That is what I have told you. Loss of basophilia is one of the reasons for increased eosinophilia. Finally, what will happen to these necrotic cells? They may be completely digested phagocytosis. Okay, they will completely disappear. Sometimes they will bind, or they will get further degraded into fatty acid. These fatty acids will further bind to calcium salts and they will undergo calcification. I will tell you, we have two types of classification: dystrophic and metastatic classification. Actually, that is we will discuss towards the end of this chapter in detail. No worries now. So fate, what is the fate of necrotic cell? Number one, it will disappear through phagocytosis. Number two, binds with calcium, undergo calcification. So here comes the questions. Okay, see, the amorphous densities. See, actually, what are these amorphous densities? Again, these amorphous densities are nothing else but they are the calcium deposits in the mitochondria. Again, this may be a question. Nuclear changes, pycnosis, karyorrhexis, and karyolysis. I hope things are very clear for you. Yes? Okay. Now we have different patterns of necrosis. Morphological patterns of necrosis. Of course, no doubt, it is a BIP question for your university exam. What is the first type of morphological pattern of necrosis? Number one is called coagulative necrosis. Coagulative means what? Coagulation. Am I right? Coagulation, denaturation of the proteins. That is the meaning. So, in this type or pattern of necrosis, the tissue architecture will be preserved. What does that mean? Once you see that organ, you can identify, oh, it is kidney, it is liver, it is heart. That is the meaning of tissue architecture is preserved. Remember, I have drawn three pictures here: a heart, liver, and kidney. That means solid organs undergo coagulative necrosis. Okay, it's not a good word, but just for your remembering, I have drawn these three pictures. In heart, we have myocardial infarction. Kidney may go for a renal infarct. Okay, see this picture. This is a wedge-shaped infarct in the kidney. Okay, and you can see there is a well preservation. See, the outlines are well demarcated. And the second picture, this is a microscopic view of that normal thing, and you can see here. See, this is eye. Okay, this is normal kidney, and this is eye. See, I have drawn the boundaries here. Also, the boundaries are here you can see various nucleus and all. You can well appreciate it. Here there is loss of nucleus. Okay, and you can see some neutrophilic infiltrate. Okay, the bluish color in between. What is this structure? They are the renal tubules. Okay, they are the renal tubules, and we can see some neutrophilic infiltrates. This blue color, don't confuse it with the nucleus. Nucleus will be present within the tubules, whereas here the nucleus are present outside the tubules. So, and on microscopic examination, there will be inflammatory infiltrate, there will be loss of nucleus, and all these we call it as ghost cells. Of course, it is a potential MCQ question. Ghost cells are a feature of coagulative necrosis. Fine. These are not mentioned in Robbins. Okay, high yield. Fine. Okay, I hope that is clear for you. Yes. So that is coagulative necrosis. It is a characteristic of infarct in all solid organs except brain. Very, very important question. Coagulative necrosis occurs in all solid organ except brain, because brain is going to undergo something what we call it as, yes, liquefactive necrosis. What is liquefactive necrosis? As a result of any bacterial or fungal infection, there will be inflammatory cells, leukocytes will come into action, they will produce some enzymes. Finally, due to the hydrolytic enzymes, the complete tissue will be liquefied. That is why it is called as liquefactive necrosis. See, you can see in this picture, this is a brain abscess. Okay, how you identify this is a brain? You can, Salkai Gaira and all you can appreciate now. Okay, so that is why I told that it is a brain. So you can see a brain abscess here. The tissue is liquefied. That is why liquefactive necrosis is also called as colliquative necrosis. It is also called as colliquative necrosis. Fine? Yes. Okay, that is the thing, and you can see pus. Okay, abscess or pus is a characteristic feature of what type of necrosis. You can go for liquefactive necrosis. We have another type of necrosis, children. Okay, another type of necrosis. Okay. That is called as gangrenous necrosis. Actually, it is not a separate pattern of necrosis. Why? Because we have two types of gangrene, bet gangrene and dry gangrene. Bet gangrene is a type of liquefactive necrosis, important MCQ question. Dry gangrene is a type of coagulative necrosis. Okay, what gangrene? Why gangrene occurs? Whenever there is a loss of blood supply, the tissues will undergo coagulative or liquefactive necrosis. And finally, what will happen? You can see dark blackish structures. The diabetes patients and all, they will get gangrene of the foot. Okay, yes. Okay, I will come to that here. What is the difference between dry gangrene and wet gangrene? Okay, one second. So dry gangrene means most commonly it involves okay. So we have dry gangrene and wet gangrene. So dry gangrene mainly it involves the lower limb. Okay, this is also a spotter question for spotters. Okay, like you have spotters in anatomy. You have spotters here in pathology also. So dry gangrene is usually involving lower limbs, and wet gangrene more commonly in bowel. Why bowel? Because bowel have microorganisms. I told you, in liquefactive necrosis, the main etiology is any bacterial or fungal infection. So remember wet for bowel. Then mechanism is important. Dry gangrene, it is arterial occlusion. Whereas in wet gangrene, it is venous occlusion. Okay, venous occlusion. And wet gangrene is liquefactive. Dry gangrene is coagulative. In macroscopy, dry means the organ will be dry or it will be black in color. Of course, the wet gangrene will be moist, soft, swollen and dark. Line of demarcation. See, this is very, very important. The line of demarcation will be present between gangrenous and healthy part. For example, so this is the foot. Okay, this is the foot of the patient. So this area, okay, these are the gangrenous area. These are the healthy areas. I am writing H. So you can see a well line of demarcation. Whereas in case of bowel, okay, these are bowel. Consider this as bowel. There won't be any line of demarcation. You can't differentiate which is healthy tissue and which is unhealthy tissues. Okay, fine. See, then I have told bacteria fails to survive here, whereas numerous bacteria is present. Of course, in gut we already have a lot of bacteria. Yes, our gut biome. Fine. So prognosis, it is generally better, whereas because there will be sepsis and okay, it will be very less. Whereas in case of wet gangrene, it is generally poor due to profound toxemia. Okay, we can't differentiate which tissue is healthy, which tissue is injured, all those stuffs. Fine. I hope things are clear. This is a very, very just draw this table. Okay, you will get 4 marks. 4 out of 4. Okay. So that's about dry gangrene and wet gangrene. Then coming into caseous necrosis. Caseous means cheese-like or the yellow-white, which refers to the yellow-white appearance on gross examination. Gross means what we are seeing with our naked eye. Histopathology means under microscopy. Fine. So on microscopic examination, what we'll be seeing? We'll be seeing some granular pink appearance. We will see what we call it as granulomas. Okay, granulomas. Okay, and we will see what clusters of macrophages. That clusters of macrophages only we call it as granuloma. As of now, don't worry about granulomas, children, because granulomas in detail we will see in chapter 2, inflammation. Okay, we have granuloma as a special topic. Okay, we will discuss there. Okay, so you can see this picture, caseous necrosis. Whenever you hear the word casus, the first thing you should come into your mind is tuberculosis of the lung. Tuberculosis of lung or tuberculosis of the intestine, whatever it may be, it will always present with a cheese-like or a caseous material. This is because the Mycobacterium tuberculosis have a very important component which is present in the cell wall. That is what we call it as. Yes, anybody know what is the compound? Mycolic acid. The mycolic acid which is present in the cell wall of the Mycobacterium tuberculosis is responsible for this cheese-like material formation. Okay, this is the lungs, children. This is the lungs. Okay, this is the apex of the lung. You know, Mycobacterium tuberculosis always tries to infect the apex of the lung because high oxygen tension. Okay, and you can see the various openings of bronchi and all. Okay, so this is a lung. This is the caseous necrosis, cheese-like necrosis. I hope things are clear for you. Yes. Next, we have something what we call it as fat necrosis. What is it? Fat necrosis. Fat necrosis occurs in regions with more fat, breast, buttocks. Then what? So of course pancreas. Okay, yes. So there will be fat destruction due to increased activity of what? Pancreatic lipase. Okay, pancreatic lipase, and as in case of what? Acute pancreatitis. So as a result of this, the fat cells will be released. Okay, and this fat cells, will either form triglyceride esters, or sometimes it will bind with calcium. Sometimes it will bind with calcium. Okay, and to form chalky white appearance. Okay, see here. Appreciate this picture. This is yellow white in color. This is yellow, that is yellow color, that is fat. Here you can see chalky deposit, somewhat white color, no? Yes, that is actually the fat which is released as a result of damage, binds with calcium to form this white chalky deposit, fat necrosis. Here comes the question. That formation, this process is what we call the saponification. You would have learned in biochemistry. Okay, saponification. Fine. Yes. Let me tell you a very important thing here. See, okay, so once again I am telling, liquefactive necrosis means abscess or pus, tissue architecture is lost. In coagulative necrosis, the tissue architecture is preserved. Wet gangrene is a type of liquefactive necrosis. Dry gangrene is a type of coagulative necrosis. So arterial occlusion. Why I say arterial occlusion? I told you, in heart, what is that? Coagulative necrosis happen. Myocardial infarction is a type of coagulative necrosis. What is the problem? The artery is going to block there, no? Coronary artery. You have learned in anatomy. But in liquefactive necrosis, okay, or in wet gangrene, like in case of intestine and all, we have more venous drainage. That there is an occlusion problem. Fine, yes. And we have examples of brain and pancreas. Here comes the question. Pancreas is an example of both liquefactive necrosis as well as, if they ask you what type of necrosis is found in pancreas, first best option is fat necrosis. Suppose, that is in case of acute pancreatitis. Suppose when the pancreas undergo any trauma, it will undergo mainly called liquefactive necrosis. Okay, it is actually again a high yield concept. They may ask in, okay, what? INICET and all those exams. Okay, so pancreas can undergo both type of necrosis. Fat necrosis in case of acute pancreatitis, and trauma it will go for liquefactive necrosis. I hope things are clear for you. Okay. Then we will go for the next or the last type of necrosis, fibrinoid necrosis. What do you mean by fibrinoid? Fibrin. That means as a result of some hypersensitivity reactions or immune mediated reactions, an antigen antibody complex will be deposited in the walls of the blood vessel, which will give rise to a fibrin formation. Okay, and that is going to give rise to a bright pink area. You can see well demarcated, no? See, these are a bright pink area. That is actually the fibrin bright pink. In staining Mauvett's pentachrome stain, I have told you the fibrin will be stained bright red in color. Yes, so whenever you see such bright red complex, you should always think about fibrin deposition. Okay, yes. So this fibrin is nothing else but a antigen antibody complex. What are the diseases you will see? Just you have to mug up as of now, because we will see each of these diseases later. Number one is PAN. PAN stands for polyarteritis nodosa. It is a disease of the blood vessel. Number 2, rheumatic heart disease. We have something called as Ashkoff nodule. We will see later. SLE, systemic lupus erythematosus. Okay, and in malignant hypertension. We have malignant hypertension. Okay, that again, all these diseases, remember PAN, RHD, SLE, all these are the diseases which includes the blood vessel. That is why I told, no, fibrin, when it deposited in the blood vessel wall, we call it as fibrinoid necrosis. Okay, yes. Okay, happening. Okay, fine. Okay. Then let us see okay, so necrosis has happened. What happened? The plasma membrane broke, the enzymes will come out. That is why in all such condition we will advise the patient to go for a blood test. For example, in patient with myocardial infarction, if you see the blood test, you can see increased troponin, increased creatine kinase. In case of liver injury, you can go for serum alanine transaminase, ALT, AST, GGT. Yes, how these enzymes are coming out? There is some injury happening inside the body. The plasma membrane blocks. The enzymes are coming out. That is how you are able to appreciate this enzyme. I hope. Okay, in the blood. I hope you can correlate. Okay, this is how you should apply practically. We know, okay, when liver injury, we will advise the patient to go for a AST ALT test. Why we are going for an AST ALT test? I am a normal person, no? I'm a normal person. No doctor is telling, Nitin, you go and take one AST ALT level. No, why? Because he's not suspecting any signs of inflammation, any signs of cell injury which is happening inside my body. That is the reason. Coming to apoptosis. Before that, there is a high yield question. Yes, 2 questions. It has been a previous year question. Senker's degeneration, typhoid, skeletal muscle injury. All these are a type of coagulative necrosis. You won't find this point anywhere. Okay, very high yield. Senker's, typhoid, skeletal muscle. All these are previous year question. What is the type of cell injury happening in chemotherapy-induced cell death? Patients who are having cancer, they will undergo chemotherapy. As a result, their cell will die. Answer is apoptosis along with the necrosis. Both will happen. If they ask for a single best answer, you have to go for apoptosis. That is the predominant way of cell destruction. What is apoptosis? It is a programmed cell death. It is a pathway of cell death in which the cells activate enzyme that degrades its own nuclear DNA, nuclear and cytoplasmic proteins. Apoptosis means falling off. It is a programmed cell death. It is a programmed cell death. Let us see what are the features of apoptosis here. Here, the cell is going to shrink. The nucleus is undergoing fragmentation to form nucleosome. Plasma membrane remains intact. So since the plasma membrane is intact, there won't be any adjacent inflammation. Remember, apoptosis may be both. It may be either physiological or it may be pathological. I will say where physiological and where pathological. Fine? Yes. Let us go for the pathway, apoptosis? Yes? Okay. Physiological, in case of embryogenesis, nucleus pulposus. Adults don't have nucleus pulposus. It is going to disappear. Yes, that pathway of disappearance is apoptosis. Pathological, in case of viral hepatitis, the liver cells, hepatocytes undergo apoptosis. As a result of this apoptosis, what will be formed finally? Councilman bodies will be formed. Okay, this is just for a high yield fact. Councilman bodies, again we will see in hepatitis in liver chapter. So viral hepatitis, the problem is Councilman bodies. These are nothing else but the apoptotic bodies. Fine. So from this, what you understand? Apoptosis is both physiological as well as pathological. Fine. Yes. So I hope the rest of the features of apoptosis also you have understood. The cell size will be reduced, fragmentation into nucleosome formation, the plasma membrane intact, no inflammation. That is very, very important. Apoptosis, inflammation is absent. Very, very important MCQ question. Fine. Once that is done, let us see what are the pathways of apoptosis. See, you can see here a normal cell which will undergo some condensation of chromatin, finally cellular fragmentation, apoptosis, and finally the apoptotic bodies will be released. Apoptotic bodies. This one such apoptotic bodies is Councilman bodies. You will see in viral hepatitis. Finally, it will be phagocytosed. Okay. Yes. So what are the physiological? See, you have a lot of example here during embryogenesis. Fine. Then turnover of proliferative tissues, involution of hormone-dependent tissue, decline of leukocyte members, elimination of potentially harmful self-reacting lymphocytes. Pathological, accumulation of misfolded proteins, infections like viral infection. Remember, whenever a body, whatever the organ may be, it's not like liver or brain, whatever, okay, all the body organs, when it has undergo some viral infection always triggers apoptosis. Just remember this point, viral infections triggers apoptosis. Okay. We have 2 pathways of apoptosis. Intrinsic pathway, extrinsic pathway. Intrinsic pathway is also called as mitochondrial pathway. Extrinsic pathway is also called as a death receptor pathway. The predominant pathway is mitochondrial pathway. Mitochondrial pathway or the intrinsic pathway. In apoptosis, we have some group of enzymes called as caspases. What are the enzymes called as caspases? Caspases stands for C for cysteine, ASP, that means they are going to cleave after aspartic acid. A stands for enzyme. Okay, yes. So what are these caspases? They are cysteine proteases that cleave proteins after aspartic acid residues. That is it. They are cysteine proteases which cleave the proteins after aspartic acid residues. We have two types of pathway. Okay, and whatever be the pathway, we have two phases. There will be an initiator phase and there will be an execution phase. Some enzymes will come and initiate the pathway. Finally, some will come and execute. That means come and digest. Okay, what apoptotic bodies. The initiator pathway is of two types. I told you, extrinsic and intrinsic pathway. So let us see what are the caspases which are involved in initiator pathway and what are the caspases which are involved in what execution pathway. In execution pathway, we have caspase 3, 6 and 7. 3, 6, 7 execution. Okay, execution. In initiator, we have 8, 9 and 10. Out of that 9 is involved in intrinsic pathway. 8 and 10 are involved in extrinsic pathway. Remember, out of this 8 is absent in humans. 10 is, so what we can say, 9 for intrinsic, 10 for extrinsic. Remember, only in humans, no, not only in humans, right, the apoptosis, necrosis, everything, even animals, they are also living beings. Okay, so they also have extrinsic pathway, intrinsic pathway, everything. So in humans, caspase 8 is absent. This has been long years back, they have asked this as a question. Which of the caspases is absent in humans? Answer is caspase 8. So 8, 10 for extrinsic, 9 for intrinsic or mitochondrial pathway. Let us see what is this extrinsic pathway. Focus on this picture because the theory is a little bit complicated. I will tell in simple terms. Suppose one cell has decided that it should undergo apoptosis. T cell, what is that T cell means? T lymphocyte will come into action. The T lymphocyte has a ligand that is called as CD95. This CD95 ligand will bind with the CD95 receptor which is present on the apoptotic cell. I have written no APOP cell, that is apoptotic cell. T cell which have the CD95 ligand will bind to the CD95 receptor, also called as the FAS receptor, okay, FAS receptor present on the surface of the apoptotic cell. And as a result, okay, it will cause trimerization of a protein. Why I say trimerization? Because, okay, I have drawn, 1, 2, 3 circles I have drawn. Trimerization of a protein, we call it as FADD. What is FADD? FADD stands for FAS associated death domain. You should know the full forms of all these. Okay, FAS associated death domain. As the result of the trimerization of FADD, procaspases or the inactive caspase number 8 and 10, because in extrinsic pathway we have caspase 8 and 10, the inactive ones will be converted into active caspases 8 and 10. And this will further what? So this is the initiator pathway, no? So once this initiator pathway is over, what will comes into action? The executioner caspases 3, 6 and 7 will comes into action. They will stimulate phagocytosis and as a result the apoptotic bodies will be removed. Okay, yes, this is the extrinsic pathway. Here comes the question, what is the marker of extrinsic pathway? Answer is CD95, because the T cell have CD95 ligand which binds with the CD95 receptors on the apoptotic cells. After, or the CD95 we can also say is the FAS ligand. As a result of this, the FADD, that is FAS associated death domain, will undergo trimerization, which will lead to activation or conversion of procaspase number 8 and 10 to caspase number 8 and 10. That is, the inactive ones are converted into active forms by FADD. And finally, the executional, the caspases will come into action and will remove the apoptotic domains. Hence, comes the question, what is the extrinsic pathway of marker, that is extrinsic pathway marker, is CD95. Okay, this has been again an MCQ question. It has been many times asked in your previous year question. CD95 is an extrinsic pathway marker. I hope things are very clear for you. Okay, happy? Okay. This extrinsic pathway is also called as death receptor pathway. Okay, this extrinsic pathway is also called as death receptor pathway. Why it is called as death receptor pathway? I will tell you now. See, here we have the death receptor pathway, because I have told you the receptor, FAS receptor. Yes, we have one more another receptor called as TNF receptor, that is tumor necrosis factor receptor. This tumor necrosis factor receptor is also a type of what FAS receptor. Sometimes it will, instead of CD95 coming and binding, the TNF receptor will come and bind. So that is why it is called as a death receptor pathway. Okay, yes. So rest things, death domain, okay, CD95, all those things, and finally clearance of the apoptotic cell. Yes, the same thing has been only mentioned here. The same thing has been only mentioned here. Fine, okay. I will tell about the executional pathway in detail. Before that, we will go for the next pathway, that is the intrinsic pathway. Intrinsic pathway is also called as mitochondrial pathway. Mitochondrial pathway. Why it is called as mitochondrial pathway? Because the mitochondria have cytochrome C. You have learned in biochemistry, cytochrome C oxidase and all. Yes, enzyme. Yes, the cytochrome C is a very important enzyme which plays a role in the mitochondrial pathway. Actually, what is happened? Suppose whenever there is some stress, like ultraviolet rays, this stress will be sensed by some group of proteins. We call it as stress sensors. I know initially it will feel a lot of what, it's so bitter, it will be difficult to understand. Okay, please watch this video in very low speed or maximum low speed. Try to understand that. Pathology is like that only. It is very, very difficult to understand. Okay, it's very, I admit that it's very difficult to understand, but no other option. You have to remember all these terminologies. You should remember all these terminologies. You should remember all the name of the proteins. Fine, because everything can be asked as an MCQ question. You have around 20 MCQs, right? Anything can be asked in MCQ. So we have no other option. You should remember all this. Whenever there is a stress, the stress will be sensed by a group of proteins called as stress sensors. What are the examples? You should remember. I'm highlighting BIM, BAD, BID, Puma, Noxa. Very difficult only, no other way, you have to by heart. BIM, BIT, BAD, Puma, Noxa. Remember all this in the form of a poem or a song. Fine? Yes. This stress sensors is going to, okay, this stress sensors will be going to, okay, just one second, I'm writing again for you here. BIM, BIT, BAD, Puma, Noxa. Okay, yes, I hope it is clear for you. Yes, BIM, BIT, BAD, Puma, Noxa. Fine, okay. These stress sensors will stimulate pro-apoptotic factors, inhibit anti-apoptotic factors. Pro-apoptotic means to stimulate apoptosis, no? So those factors should be encouraged. At the same time, the proteins which is going to inhibit apoptosis, we call it as anti-apoptotic factors, they should be inhibited or discouraged. Here comes the question, what are the pro-apoptotic factors? What are the anti-apoptotic factors? Remember children, I am telling again, MCQ books have lot of errors. Some of the MCQ books, they have mentioned the stress sensors also as pro-apoptotic factors. They are stress sensors, they are a separate family. These stress sensors may either promote or inhibit apoptosis. So we can't say that they are pro-apoptotic factors. We have a lot of pro-apoptotic factors. This is a 10th edition update. In 10th edition, it is very beautifully mentioned. What are the pro-apoptotic factors? P53, BAX, BCLX, yes. BCLX, yes. I know, very difficult, no other way. P53, BAX, BCLXs. They are encouraged. What are discouraged? Anti-apoptotic factors. This is an MCQ. There is no way at any cost, you can't skip this portion. Anti-apoptotic factors are BCL2, BCLXL, MCL1. BCLXL is anti-apoptotic, whereas BCLXS is pro-apoptotics. Okay, yes, no worries. You just revise it again and again. You will get to use the, because all these are very basic. Okay, for example, we have a lot of leukemias and lymphomas. In that, we are going to discuss all these only. So at that time, if you don't know what is BCL2, which is BCLXL, you have to again mark up that. So try to understand and keep in your brain, okay, or else don't try to mug up. It won't last for, I'm telling you, it won't last in your brain for more than 48 hours. So BCL2, BCLXL and MCL1, all this will stimulate the mitochondria. The mitochondria will further release two set of compounds, chemicals, or number one is cytochrome C. I have told you initially, this cytochrome C is going to activate APAF. Okay, APAF1. What is APAF1? Apoptosis activating factor. APAF means apoptosis activating factor. So cytochrome C will activate APAF1. This will result to the formation of apoptosome or apoptic bodies. I told you, yes, which will looks like a wheel, like hexamer, like this. Okay, hexamer like this. Okay, and this will further stimulate the conversion of procaspase 9, because intrinsic pathway we have 9, extrinsic pathway only we have caspase 8 and 10. The procaspase 9 will be converted into caspase 9. Procaspase 9 is converted into caspase 9. I hope it is very clear for you. Yes, and further this will stimulate the execution pathway of apoptosis, that is phagocytosis. I hope 3, 6, 7. Okay, yes. So that is one set of compound. At the same time, it will stimulate SMAC and Diablo. These are another set of proteins. What are they? SMAC, SMAC and Diablo 1. These proteins are going to inhibit IAP. What is IAP? IAP stands for inhibitors of apoptosis. Inhibitors should be inhibited. That means finally what is the result? Minus into minus is plus. When he inhibits the inhibitors, the apoptosis will be stimulated. Apoptosis will be encouraged. That is it. We have to discourage the inhibitors to encourage the apoptosis. That is the reason. Okay. When we inhibit the inhibitors of apoptosis, the final pathway will be pro-apoptotic. Okay. Yes. So these two pathways will come into action. I hope things are clear for you. Yes. So once this is done, we have execution pathway. What is the execution pathway, children? Activation of 3, 6 and 7 as a result of initiator pathway. So apoptotic bodies are formed. Okay, there all the stuffs are formed in the extrinsic pathway. It will activate 3, 6 and 7. Enzymes, phospholipase and endonuclease will come into action. It will cause internucleosomal cleavage. Here the plasma membrane is intact. There is no enzyme leakage. And finally, it will lead to apoptotic body. Apoptotic body will be looking like this. It will be having some 2 layers. Actually, these layers are made up of phosphatidylserine. And that is why phosphatidylserine is used as a marker for apoptosis. How I told you, in extrinsic pathway, we have CD95. Here, phosphatidylserine, we have another marker that is called as, so that is actually a marker for intrinsic pathway of apoptosis. That is actually a marker for what part? Intrinsic pathway of apoptosis. I hope it is clear for you. Phosphatidylserine, okay, 2 layers used for a marker of apoptosis. Okay, so the activation of enzymes, internucleosomal cleavage and apoptotic bodies. What are the hallmarks of apoptosis? Number 1, nuclear condensation, cellular shrinkage, eosinophilia, hyperchromasia. Hyperchromasia means increased density of the nucleus, that is we call it as hyperchromasia. Okay, yes, the chromatin will be appearing so dense or so thick in color. Fine, yes, that is more eosinophilia, more what I can say, the chromatin condensation. That is another terminology for that. Is what I have mentioned here, no, nuclear condensation. Fine. So these are the hallmark features of apoptosis. So what all we have discussed, see the same thing only they have mentioned here also. Okay, you can go through these pictures. Okay, whenever they stress BH3, BCL2, okay, all those stuffs they have mentioned here. Okay, it is a little bit confusing. That is why I have written it separately. Please remember, please follow this. You should know what are the stress sensors, what are the pro-apoptotic, what are the anti-apoptotic. Anti-apoptotic you cannot skip at any cost. BCL2, BCLXL and MCL1. Then SMAC, Diablo, cytochrome C, those 2 things you should know. Okay, yes. And whenever you heard the word apoptosis, you should know an enzyme. What is that? Caspases. But remember, in neurons, we don't have caspase. In neurons, we don't have caspase. Hence in neurons, the hallmarks of neuronal apoptosis is APOF1. What is APOF1? Apoptosis activating factor 1. Yes, in all other cells, we can go for caspases as hallmarks or hallmark marker of the new apoptosis. Okay, whether it is both extrinsic pathway or intrinsic pathway. Generally, if they are asking what is the hallmark marker for apoptosis, means you can go for caspase. If they ask you separately extrinsic pathway, means we will go for CD95. Intrinsic pathway, we have lot of marker. Out of that, I told you, phosphatidylserine, or we have something called as annexin 5. That is annexin 5 is a much more specific marker than phosphatidylserine. I will tell you what are the markers of apoptosis very soon. So in hallmarks of neuronal apoptosis, since neurons don't have caspases, they will go for APOF1. APOF1 is the hallmark of neuronal apoptosis. Yes, a very important terminology. Okay, very important terminology. Okay, which is mentioned in Robbins' 10th edition is called as efferocytosis. Efferocytosis, I have written the page number 46. It is a new term which is introduced in the Robbins book. Actually, what is it? It is actually a specialized type of phagocytosis of apoptotic bodies. I told you, the apoptotic bodies will undergo what phagocytosis? Yes, it is a specialized type of phagocytosis. Here, the various ligands will bind to the apoptotic bodies, and finally, it will generate an eat me signal. That is, it will send some signals. Yo, you come and eat me, like that. Okay? Yes. And it is mainly carried out by macrophages and dendritic cells. Dendritic cells, antigen presenting cells. Yes, of course, the fibroblast and other epithelial cells also take part in efferocytosis. What is efferocytosis? It is a new terminology for the phagocytosis of apoptotic body. Phagocytosis of apoptotic bodies, we call it as efferocytosis, mainly by macrophages and dendritic cell. Of course, maybe also by fibroblast and the epithelial cells. Okay, yes, I hope it is clear for you. These are the hallmarks of what we call it as apoptosis. We have studied about apoptosis as well as necrosis also. And remember in Robbins' 10th edition, we have another one important point that I will tell you, that is in extrinsic pathway. See, here I have mentioned about flip. See, actually some viruses have a protein called as flip. This protein will inhibit the conversion of procaspases into caspases. As a result of this, apoptosis cannot proceed. So the flip is actually a protective mechanism used by some viruses to protect from our body's immunity, or else the virus will be killed through apoptosis. So in order to protect that, they will express some proteins called as the flip proteins. They will express some proteins called as the flip proteins, and they are anti-apoptotic. Yes, this is the question. Which of the following are anti-apoptotic? Means, of course, in the option flip is there, you can also mark flip, because of course it is not present within our body, it is present in the virus, but that is used. This protein will help the virus to protect themselves from the body's immunity. Fine. Yes, I hope that is clear for you. Okay. Yes. So what all we have discussed? We have discussed the death receptor pathway. See, these are the pathway you can see here. Fast ligand we have. Okay, fast ligand means immediately you should remember it is an extrinsic pathway. We have FAD. Okay, procaspase becomes active caspase. Then finally apoptosis. Fine. See, you can hear Robbins' 10th edition. This is efferocytosis. See, here they have discussed about the flip protein. Execution phase, we have 3, 6, 7. Remember 3, 6 and 7. Okay, yes. So that finishes the what we call it as apoptosis. That finishes the apoptosis. Then what I am going to discuss is the other mechanisms of cell death. That is what we call it as necroptosis. Necroptosis means it has the features of both necrosis and apoptosis. What are the features? It resembles in that of necrosis: loss of ATP, swelling of the cell, reactive oxygen species formation, all those. Whereas the pathway is always similar to that of apoptosis. So morphologically it looks like necrosis, but in mechanism wise it looks similar to apoptosis. That is why we call it as a programmed necrosis. Remember, it is a caspase independent programmed cell death. Why? How it differs from apoptosis? Okay, first I am telling necroptosis. It has features of necrosis morphologically. It has features similar to apoptosis by mechanism. Then here comes the question, how it then differs from necrosis, how it differs from apoptosis. It differs from necrosis in one way. What is the reason? What is the way? It is programmed. Yes, necrosis is not programmed. How it differs from apoptosis? Apoptosis is caspase dependent pathway. Necroptosis is caspase independent pathway. Okay, yes. Remember children, it has been asked in my university exam Pathology University exam as a short note version. No one will expect this question. It has been very only detailed, in detail it has been mentioned only in Robbins 10th edition. Fine. Here we have TNF, tumor necrosis factor, which will binds with the TNFR, that is tumor necrosis factor receptor, which will leads to the which will activate a complex of protein called as RIP. RIP, it's not RIP death. RIP stands for receptor interacting protein kinase 1. Okay, it will activate two set of protein, that is RIPK1 and RIPK2, and finally this will convert the inactive. So this will lead. This is don't write any caspases here because it is a caspase independent pathway. Finally, this will causes phosphorylation of MLKL. Okay, it is a cytoplasmic protein MLKL. Actually, this MLKL protein will be further activated, and as a result of this, what will happen? Plasma membrane disruption. See, in apoptosis, the plasma membrane is intact. So this is also a difference, then, which will cause tissue damage, then necroptosis and inflammation. Remember, in necroptosis, inflammation is present. In apoptosis, inflammation is absent because plasma membrane is intact. Apoptosis, caspase is present. Here it is caspase independent. What are the proteins involved here? RIPK1, RIPK3. Then finally, it will act to a cytoplasmic protein called MLKL, which causes plasma membrane disruption. Okay, I hope this is clear for you. Yes. Again, this necroptosis, because it is a combination of necrosis and apoptosis, it may be either physiological or it will be pathological. So, what are the examples of physiological necroptosis? That is mammalian growth plate. Mammalian growth plate. Pathological, steatohepatitis. Liver, it's a liver pathology. Acute pancreatitis. Ischemia reperfusion injury. I will tell what is ischemia reperfusion injury in the next session. Then added Parkinson's disease. And here comes the question. Here comes the question which has been asked in AIMS. Which of the following pathways has been adopted by the cytomegalovirus? Cytomegalovirus as a host defense mechanism. Answer is answer is necroptosis. So the cytomegalovirus use this pathway of necroptosis. It's not necrosis or apoptosis. The usually the virus will inhibit the apoptosis pathway, whereas cytomegalovirus, it is a very special virus you will learn in microbiology. It is going to adopt the necroptosis pathway. Okay, I hope things are clear for you. Okay, good. Then coming into pyroptosis. Pyro means what? Fever. So this pathway is going to finally produce fever. It is a this pathway of apoptosis is because of a protein or a caspase called as caspase 1, caspase 11, interleukin 1. All 111. Okay, remember caspase 1, caspase 11, interleukin 1. Of course, interleukin 11. Then sometimes caspase 4 and 5, but don't remember that. Remember 1, 1, 1, all 1, rule of 1 for pyroptosis. Caspase 1, caspase 11, interleukin 1, interleukin 11. All these are fever-inducing cytokine. They will finally lead to a formation of an inflammasome. I will tell what is inflammasome in the chapter of inflammation. Finally, all this will be formed. As a result, what will happen? Yes, leukocytes will be coming into action, phagocytosis, rest all mechanism is same. But what is the differentiating feature of pyroptosis? Because of this interleukin 1, 11, caspase 1 and 11, finally, fever will be produced. Okay, it is a fever-inducing mechanism of cell injury. Okay, it is a irreversible cell injury which finally leads in fever. Okay, I hope you are clear for that. Yes? Okay. See? Let us see this pyroptosis in detail. Okay, see here, pyroptosis. Just forget what is canonical and non-canonical. Okay, some bacteria like Salmonella and Shigella. Why I have mentioned these are the two important bacteria which, like I told, cytomegalovirus uses necroptosis. Similarly, Salmonella and Shigella, S and S, Salmonella and Shigella both uses this pyroptosis pathway, and this pyroptosis pathway will finally do like procaspase 1 will be converted into active caspase 1, all those stuffs. Okay, finally what caspase 11, caspase 1, interleukin 11, finally what will happen? Pyroptosis or some inflammatory response will happen. Here inflammation is present. Let us discuss the furthermore detail of this, what is inflammasome, all those in inflammation chapter. Here comes a question. This has been asked in AIMS PG. Nobody will predict, no books it has been mentioned, but they have asked this question. Actually, I got this picture from a journal from Google. Actually, what is gas dermin D? See, I told you, the caspase 1, caspase 11 and all, they will cleave this gas dermin D, which is actually a protein. The gas dermin D protein cleavage, this is responsible for the release of interleukin 1 and 11, which will further produce or induce fever production. So what was the question they have been asked in AIMS PG? Which of the following proteins are involved in pyroptosis? Answer in that option, it was gasdermin D, or I think gasdermin D is involved in which of the following type of cell injury pathway? Answer is pyroptosis, because the active caspase 1 and caspase 11 will cleave this gasdermin D protein, and this gasdermin D protein cleavage is responsible for activation of interleukin 1, which further produces what? Fever. Okay, yes, this has been a very important question. I am writing, it is very, very important. Okay, I hope it is clear for you. Okay, once this is done, let us see the next pathway, that is ferroptosis. Again, a 10th edition update. Iron induced cell death. You have learned in biochemistry, iron will produce free radicals, Fenton reaction. Yes, the free radicals is responsible for the injury. Okay, free radical is responsible for the injury. Not that much significant. Just remember, it is an iron induced cell death. Okay, yes. Here you have to remember 2 points. What are the specific electron microscopic findings? It is electron microscopic findings. The number 1 is what we call it as loss of crista, and number 2 is rupture of the membrane. These two are the characteristic electron microscopic. It's not mentioned in Robbins and all. High yield. Okay, these are high yield points. Okay, electron microscopic findings, loss of crystal and rupture of membrane. These are star. Okay, you can, of course, these are potential PG MCQ questions in the future. Let us see this pathway of ferroptosis. Again, it's from Google. Okay, forget about all those stuffs. Further about all those stuffs, don't forget about what are the terminologies they have given. Okay, just remember, it is an iron-induced cell death. Iron will stimulate the free radical formation that is responsible for cell injury. Okay, you have a Fenton reaction. If you want, you can refer your biochemistry textbook for that. Here comes the one and only question. Again, this has been asked in PGI, a Central Institute exam. What is the master regulator? Which gene is the master regulator of ferroptosis? Answer is GPX4. Just remember, in order to show that only, I have inserted this picture. GPX4. See, GPX4 is the master regulator of ferroptosis. We have some other terminology, what we call it as anoikis. What is it? Anoikis. Sometimes, I think in some chapter 6 or chapter 7 in Robbins, they have somewhere they have mentioned about this word anoikis. So actually, what is anoikis? Anoikis means loss of natural environment. It is also a type of cell injury in which there will be loss of natural environment, or I can more specifically say like loss of basement membrane. Okay, basement, cells, you have epithelium, the epithelium lies on a basement membrane. Okay, the loss of basement membrane is also sometimes called as anoikis, but a more better answer you can go for loss of natural environment, we call it as anoikis. Just okay, you should, when somebody tells his name anoikis, you should not say, oh, I don't know. No, anoikis means it is actually a type of cell injury, okay, which finally is because of the loss of natural environment. Let us see for some of the high yield fact. I have told you Senker's degeneration, typhoid, skeletal muscle injury, all those are examples of coagulative necrosis. In Senker's degeneration, what are the muscles which are most commonly involved? The answer is rectus abdominis and diaphragm. Of course, in Senker's degeneration, the skeletal muscles are also involved. All these are examples of coagulative necrosis. Here comes the question, what is the earliest damage or the earliest change in a reversible injury? Answer, I have told you, cellular swelling. Then what is the major factor in irreversible cell injury? It is membrane damage. I have told you 3 importance, that is mitochondrial damage, membrane damage, DNA integrity loss. Out of that, the most predominant, the single best answer is membrane damage. Okay, these are some of the high yield facts for your next and the INICET exams. Okay, please focus on that. Okay, yes. One second. Okay, and so I think these are the various concepts, okay, we have learnt. Then next I am going to say about some of the apoptosis assays. One second. Okay. We are going to see some of the apoptosis assays. Okay. So I hope things are clear for you. We have discussed from the starting, we have discussed for the last 1 hour, we have been discussing about, okay, the overview, what are the causes of cell injury, we have discussed about, see, everything is important, children. I can't even skip any of the point. That is why it is taking this much time. Even I can, okay, tell all those stuffs in a very, like in a 10 minutes or 30 minutes, but that is not going to give you anything. Fine, you should know this message because this is the very first chapter. No, if you don't take, okay, like if it is a case of like, what if it has systemic pathology and all, okay, I can see just the salient features. Because here I have to explain each and every terminology because you are completely new to all this term. I can't skip to say what is FAS. Okay, of course I should say what is the full form of FAT, that FAT is FAS associated death domain. I should explain each and every terminology, its abbreviations, okay, its expansion, everything. Or else because hereafter in every chapter of Robbins, you won't see the complete expansion. They will just see, okay, BCL2. Okay, immediately you should remember, oh, BCL2, it is an anti-apoptotic protein. Oh, this is a pro-apoptotic protein. So I can't skip anything. Everything is important. Each one is an MCQ question. Fine, of course, from this chapter you may get a single MCQ in your PG entrance exam, but you can't imagine what question may be it. Okay, you can't even predict. No chance of prediction itself. Fine, yes. So all the morphological patterns, coagulative, wet gangrene, dry gangrene. Wet gangrene, dry gangrene is a short note question. That's why I have discussed. Okay, actually it's not mentioned here. Okay, I have taken a picture from Google and I have mentioned that intrinsic pathway, extrinsic pathway. Okay, that is from this chapter, the most potential essay question is define apoptosis, explain in detail about the intrinsic and extrinsic pathway of apoptosis, and add a note on the morphological changes on apoptosis. Or they may say add a note on ferroptosis, add a note on pyroptosis. The pyroptosis, necroptosis, both individually can be asked as a short note question. Morphological patterns of necrosis is another short note question. So everything, okay, yes. Then efferocytosis, all those stuffs I have told you. Next, I'm going to tell you about various assays. Okay, assays for apoptosis. It is actually mainly for INICET, Institute of National Importance, Common Entrance Test. Number 1, membrane permeability assay. Out of that, okay, we have impermeable dyes, permeable DNA stain. The most important thing is annexin 5. Most important is annexin 5. Annexin 5 is the most important. It is the best marker. I told you, phosphatidylserine. Actually, in this annexin 5 assay, we are actually detecting the phosphatidylserine only. Fine. Yes. In extrinsic pathway, I have told you it is CD95. Then we have some nuclear events and DNA cleavage assays, that is agarose gel electrophoresis. Then DNA cleavage in situ. We have in situ NIC translation. We have something what we call it as tunnel assay. What is the full form of tunnel? Yes, this has been asked once. Tunnel stands for TDT, DUDP. NIC end labeling, TDT, DUDP, all these are nucleotides name. Okay, terminal deoxy transferase, that is TDT, terminal transferase. We are using a terminal transferase. We are labeling the DNA, okay, the ends of the DNA, and finally we are interpreting the result. Remember, if the tunnel assay is positive, it is apoptosis, PO. See, PO. Positive, it is apoptosis. If it is negative, NENE, it is necrosis. Fine, yes. Then we can also assess the cytoplasmic biochemical activities, that is by assessing the levels of trans-glutaminase activity. All these are non-specific, but sometimes we can also assess the caspase activity. We can also assess the PARP, okay, activity. All these are non-specific. Remember, annexin 5 and tunnel. Of course, we can use flow cytometry. Okay, see, we can. So the best marker is annexin 5 assay. Okay, annexin 5 assay. Okay. And yes, then next most important thing, and the last thing I'm going to tell is gel electrophoresis. I told you in agarose gel electrophoresis also we can detect this. See, in agarose gel electrophoresis we will see various patterns. Okay, this is a characteristic pattern. See, this is an agarose gel electrophoresis. Okay, yes, fine. Okay, this is normal pa. A is normal. B, you can see steps 1, 2, 3. You can see step. This is called a step ladder pattern. This is called a step ladder pattern. It is seen in apoptosis. Why there is a step ladder pattern? I told you this. Actually, in agarose gel electrophoresis, we are going to assess the DNA. In apoptosis, in the execution pathway, I told you there is internucleosomal cleavage. The nucleus are cleavaged part by part. So that is responsible for this step ladder pattern. This characteristic pathway is called as step ladder pattern, which is seen in apoptosis. Okay, it has been asked in the Ames assertion recent question. Step ladder pattern in apoptosis is because of. Answer is due to the internucleosomal cleavage, and they have also asked about the number of base pairs. That is, the enzyme will cleave 180 base pairs at a time. It will cleave 180 base pairs at a time. Okay, yes, and like 180, 180, 180, that is responsible for the stepladder pattern. Here you can see another pattern like a smear. How you make a peripheral smear? No, this is called a smear pattern. Smear pattern in agrogel electrophoresis is necrosis. They will simply give this picture. Okay, in exam, no history, nothing. They will simply give this picture, and finally they will ask you what is A, B, and C. You have to write very confidently. So A is normal, B is apoptosis, and C is necrosis. Apoptosis stepladder pattern, C is what we call it as a smear pattern. You have to very confidently write. Okay, annexin 5. Remember, annexin, we have various markers. Annexin 5 is for apoptosis, and in hematology, I will say annexin A1. It is a marker of hairy cell leukemia. Hairy cell leukemia. Annexin A1, this is annexin 5. 5 for apoptosis, A1 for hairy cell leukemia. So that finishes the apoptosis assays. Okay. So I think a lot I have told you today. Lot, of course. And please go through all those stuffs. Fine. Yes, all those you have to please focus on each and every point. You can't skip even a single point from this. Please go through everything, and if anything, let me know that. Fine, or you can give your comments. And please go through all the updates, necroptosis, pyroptosis, nephrocitosis. Those who are following all the editions of Robbins, please go through this terminology. This and all only mentioned. Okay, that's why I have included these pages also here in necroptosis. See, this is all the pages what I have included from the 10th edition. So please go through all those things. So in the next session, we will be starting with the autophagy. What is autophagy? Then what are the what cellular adaptation, intracellular accumulation, and the cell aging. Thank you.